thank you for joining us tonight. This is a VBS Direct collaboration with HT Vista. And last year, Lyron, who's also listening and involved with the UK aspect and globally. And then Gillian, who's based over in Israel and is a veterinary oncologist, having done her diplomas over in the USA, is very kindly joining us tonight to go and give us further insight into this exciting new area for improving our diagnostic decision process in canine skin tumors. So I will hand over to Gillian. I will turn off my but you'll notice at the bottom there is a chat and there's also a Q&A. So if you are if you would like to go and ask Gillian questions, I would advise you to use one of the boxes down at the bottom, and then at the end of it we can spend some time doing questions at the end. But at this point I hand over to Gillian, and thank you very much. I'll let you introduce a little bit about yourself.
Thank you very much. So my name is Gillian. I'm a veterinary oncologist. I did my vet school at Hebrew University in Israel, and then I went for my residency at University of California at Davis. After I finished my residency in oncology and was boarded as a diplomat of the ACVIM, I came back to Israel, and I'm now boarded in ECVIM at that time. I worked for over 20 years at Hebrew University. 3 years ago, I left Hebrew University, and I've been in private practice since that time. And I've been working with HT Vista, which I think is really, really exciting. And there are a lot of things that we can, that it can help us be better veterinarians. And it's really cutting edge technology that everybody should hear about. So the purpose of the lecture today is to talk about mast cell tumors, because that's a tumor that everybody in general practice looks at and sees all the time. So the title of the lecture is Who Has a Better Prognosis After They Were Diagnosed with Mast Cell Tumors, either Siggy or Joy. So Siggy is a female spayed 5-year-old pit bull mix. She has no issues in her history, and her owners noticed 3 small masses in the past month. The masses are all 0.8 to 1 centimeter, cutaneous, and easily movable. So what do we do when we see these kind of dogs in the clinic? Obviously, everything in clinics and in veterinary oncology has options. The first options is to say, wait and see. I'm a really busy GP. I have no time to deal with this. I have a million people waiting for me outside. But as an oncologist, I rarely agree with this. And unfortunately, I was surprised to hear how common this is. And the reason I disagree with this is because there are many, many different types of cancer. And the earlier we diagnose them, and then the better we can treat them, and the dogs can go home with a better prognosis. So we now know that 50% of the masses and lumps and bumps that come into the clinic leave undiagnosed, at least 50%. And our purpose, obviously, is to get better at that. So what do we want to do with Siggy and pretty much every dog that comes into your clinic? We want to be proactive and diagnose those tumors. It's what all of the veterinary oncologists recommend, no matter which country they are or where they are in the world. We don't want to send dogs home with cancer. So whenever a mass comes into your clinic, the most important thing to do on your physical exam is describe the mass. And there are all sorts of different words that can help you describe the mass. And the importance of this is because we're all really busy. And if we see a dog today and then we see them again next week or in a couple of days, pretty much the chances of remembering exactly the size, the consistency, and what this dog had, if you're really busy, are very small. And the more you describe it in the files, there's more of a chance that you're actually going to remember or be able to compare what's happened since you saw it. So the words that we want to use to describe masses are the size in centimeters. So we actually want to have a caliper or a ruler, but a caliper is much better to actually understand what the exact size of this mass is. Is it a centimeter? Is it 5 centimeters, which is a huge difference? If for some reason you don't have a caliper in your clinic, which is unfortunate, then the best way to describe it is probably like the fruits. So you could say it's the size of a different kind of fruit. Is it the size of an orange? Is it the size of the mandarin orange? Is it the size of an apricot? And all sorts of things like that. Because people kind of usually understand how to compare that. Is it pea size? Because everybody knows what those sizes are. After size, we want to say, is it firm? Is it soft? The location of the mass on the body. Is it ulcerated? Is it cutaneous or subcutaneous? Is it circumscribed or edematous? Is it painful? Isn't it freely movable? So all of these words all together will be able to understand what we're dealing with. So if you're going to talk to one of your colleagues the next day and say, oh, I saw this mass yesterday, well, nobody's going to know what you're talking about. But once you use all these words, the person that you're talking with actually understands what you're talking about. So in Siki's case, there are 3 cutaneous masses, all under 1 centimeter, all easily movable, and all circumscribed. So what are our differentials? So obviously differentials are very important in veterinary medicine, and we have to learn them in veterinary school, and they're very, very useful even when we're vets. So the differentials for cutaneous masses, if obviously could be either non-neoplastic or neoplastic. And if we're talking about neoplastic, we split them into 3 different categories. We have round cell tumors, sarcomas, mesenchymal tumors, and carcinomas or epithelial tumors. When we're talking about the round cell tumors, we have 5 different types of tumors. We have mast cell tumors, histiocytic tumors, plasma cell tumors, lymphomas, and TVTs. So after we know those 5, we want to understand which of those is appropriate for this specific dog in this specific case. And as I'm sure you understand, lymphoma, TVT, and histiocytic sarcomas are not appropriate. First of all, for lymphoma, this isn't in a location of lymph nodes, and this doesn't appear to be cutaneous lymphoma. TVT is not appropriate from a location point of view, and histiocytic sarcomas are subcutaneous tumors and not cutaneous, so this is not appropriate. So the tumors that could be appropriate for a differential list would be mast cell tumors, histiocytomas, which obviously are cutaneous, and plasma cell tumors. Sarcomas are less likely because the mass is cutaneous. The most common sarcomas that we see are angiopericytoma, fibrosarcoma, and hemangiosarcoma. Many other sarcomas might cause lameness or cause pain, but these are less appropriate. And in terms of carcinomas, obviously it could be squamous cell carcinoma or sebaceous adenomas. So what is our plan? So when we have a dog with multiple masses, there are a couple of things that we need to understand. First of all is the fact that one might be malignant doesn't mean that they all are. And the fact that one is tumor X, whatever that is, doesn't mean they're all the same tumor type. And even if they are, it's not necessarily the end of the world. So I'm just going to tell you about a dog that I saw once from a veterinary student, of course, that came into me crying, because she went to her vet, and her vet aspirated one tumor from her dog and found that it was a melanoma. So she came into me because she said that her dog had 20 masses, and the dog most likely had 20 different melanomas all over his body. And obviously, as I'm sure you understand, that is just not likely because dogs don't have 20 melanomas all over their body. And if they do, maybe I've seen like 1 or 2 of those in my life, it's really, really bad, but it's very unlikely. So what you have to do in every one of those cases, as annoying as it is check out each mass, because the fact that there's 1 melanoma doesn't mean they all are. And in her case, the dog had 1 melanoma, 1 mast cell tumor, a couple sebaceous adenomas, a couple lipomas. So again, the fact that one is malignant doesn't mean they all are. And the fact that one happens to be a melanoma doesn't mean they all are. So it is critical to check all the masses, even though we know it's much easier, especially when they're a couple, to just send them home. So how are we going to check out these masses? So wouldn't it be amazing if we could know if a lump is benign without doing aspirates and biopsies with a non-invasive approach? So that way we know if the mass is benign, and then you can just send them home. If not, you can recognize and rationalize that you need to work up the case with an aspirate or a biopsy. So this is new world, cutting edge technology, HD Vista. So HD Vista is the only non-invasive cancer screening tool for lumps and bumps, and it allows your veterinarians or technicians to rule out cancer on the spot in your clinic. So far we've written up 2 articles on the HD Vista. The first was the pilot study for the system, and the second was a training and validation study. The second was in 664 masses and showed 90% sensitivity and 98% negative predictive value, which means that if this shows that the mass is benign, it really has a huge chance of 98% of chance of being benign. So we're not going to send the dogs home with cancer. So the principle behind the technology is that benign and malignant tissues display different heat transfer rates due to difference in their composition, metabolism, tissue morphology, and their vascular network. And this affects their thermophysiological properties. So this screening model relies on the unique thermal signals that are recorded by the device as the tissue is heated and then left to cool down. So obviously there are other things out there, other devices that are looking at baseline thermal imaging, but what's special here is that we're heating it up, cooling it down, and watching what happens over time. So here you can see the handheld device, and you can see that we have the camera, we have a heat source, and we have a thermal sensor. Again, everything happening together to give the algorithm as much information as possible so you can get the right answer. So this is what happens throughout the scan. You can see that the scan is heating up the tissue. The red is the heat, and then watching the tissue as it cools down. You can see that the mass on the left and the right are not the same. The one on the left is a tumor. The one on the right of the screen is regular tissue. And so we're heating them both up, allowing them to cool down. The entire scan is only 40 seconds. And then the algorithm is comparing the delta between the mass and the regular tissue. We always need the mass and the regular tissue to look at their differences to allow us to understand, and for the algorithm to understand the differences and what's going on. So what's also critical about this process is that it's technician-led. So we understand that you as veterinarians are super busy throughout your day, and you really don't have time to start doing more stuff. But if you can get your technicians to get excited about this, so the technicians who are great and looking for additional high-tech stuff to do and exciting things to do, they can actually prep your patients, scan them, get the results, and then come to you with the results. So you don't even have to do this. This is something they can do easily, get used to, and then just give you the results. And these are the results that we can see here. So the results are on a scale of 1 to 10. The lower the result, lower the result, the higher the chances of that you need to further work up this dog. The higher the result, the higher chance that it is benign. You can send them home happily. So what happened in our case? So in our case, there were 3 masses, and we scanned all 3 masses. And here you can see that this mass received a 1. So the probability that it's benign is only 39%, which means we need to work up this dog. Same with the second mass, and same with the third mass. Again, these masses may be inflammation, may be infection, but they also may be tumor. And that's why we cannot send them home. So we need to plan, what are we going to do diagnostically? And in this case, anytime we have a suspicious mass, the next thing we want to do is a fine needle aspirate. So in her case, obviously, we need to aspirate all 3 masses, because the fact that one is mass X doesn't mean they're all going to be the same thing. So in her case, we did a fine needle aspirate and found this. So as I'm sure you all know, these cells are round cells, and due to all of the granules that we see in them, the purple granules, this is diagnostic for a mast cell tumor. So what are we going to do now? What are we going to tell the owners? She has 3 tumors, 3 mast cell tumors. Is that good, bad, horrendous? So in order to understand that, we need to discuss a little bit of mast cell tumors and about their biology. So back to the basics. So canine mast cell tumors, the most common tumors in dogs, cutaneous tumors in dogs. The etiology is unknown, and the mean age is 9 years. There's no sex predilection, and the breed predilection can be in boxers, bulldogs, terriers, retrievers, and Shar-Peis. The history and clinical signs is usually a mass noticed by the owner. Clinical signs are due to release of histamine and heparin, and the location can be anywhere throughout the body. 10% of dogs have been reported to have multiple cutaneous tumors, and systemic mastocytosis has also been associated with cutaneous tumors. So any dog or cat that I see with a tumor, I basically look at them look at veterinary oncology as any tumor or any dog. There are 3 steps that we need to do. So this is my 3-step approach that obviously I was taught. I didn't make anything up, but I think it really helps me looking at all of my different cases. So the first step in any case I see is getting a diagnosis. Doesn't matter what tumor they have. Obviously, we're talking about mast cell tumors, but it's the same for every single tumor we see, getting a diagnosis. The second stage, after we know what the diagnosis is staging. How much has that disease spread throughout the body? Has the cancer spread? Has it metastasized? So obviously, in order to understand how to stage that dog, we need to know what the diagnosis is, because different tumor types have different staging tests. So some tumors, like carcinomas, may spread through the lymphatics, and then we need to aspirate the local lymph nodes. And then from there, they might go to the lungs, and then we need to do thoracic radiographs. And others may spread through the bloodstream, and then we don't need to do lymph node aspirates, but we need to do thoracic radiographs. Others may spread to the abdominal organs. So we need to know the diagnosis, we need to know the biologics, and then we can know which tests to do in order to understand, has it metastasized or not? And then obviously the third step is, after we know the tumor type, the stage, then we can tell the owners what they want to know. And obviously that's treatment options and prognosis. So what is the first step, and how are we going to get a diagnosis of mast cell tumors? Obviously, an aspirate is the best answer. In 99% of the cases of a mast cell tumor, it's enough to do an aspirate, and we can know the diagnosis that this is indeed a mast cell tumor. So one little catch, which I'm sure many of you remember from vet school, if you haven't seen it in practice, is that some mast cell tumors are problematic when you're staining them for Diff-Quick, and the granules may dissolve in the Diff-Quick, and you may get a smear of a round cell tumor with no granules. If you suspect a mast cell tumor, then you need to send that off to a lab to be stained by the laboratory's professional staining. So Diff-Quick can be problematic. It's rare, but it can happen, and you just need to remember clinically, do I think it's a mast cell tumor? Might there be a problem here? If yes, then send it off to the external lab. Second step is staging. So in mast cell tumors, we have two different types of staging. We have minimal staging and complete staging. And in some cases, complete staging may not be necessary. So the decision between minimal or complete staging depends on the dog. So on the prognostic factors that we're going to discuss soon, on systemic signs. So if the dog's sick, we're always going to do complete staging. And on tumor location, which is one of the more important prognostic factors. And obviously, everything we do in veterinary medicine depends on the owners. So it's not wrong to completely stage. It just could be more staging, more time, more tests, and obviously more money. So minimal staging is required in all dogs diagnosed with a mast cell tumor. And minimal staging is a fine needle aspirate of the regional lymph node. So the advantages of this test is that it's not invasive and it's inexpensive, but the disadvantage is that sometimes it's difficult to interpret. So draining a lymph node that's draining mast cells from a tumor bed could actually have mast cells, but it's not necessarily metastatic. So in these cases, I highly recommend that you send it to a clinical pathologist to understand whether it's just draining or metastasis. And they have all sorts of criteria to decide that based on the number of mast cell tumors, whether there are clusters, and all sorts of things like that. So complete staging in cases with poor prognostic indicators includes a CBC panel urinalysis. On the CBC, we may see anemia, we may see eosinophilia. Imaging, so we want to do abdominal ultrasound, and in some cases, we may do thoracic radiographs, which is less important. The reasons to do thoracic radiographs is we might see enlarged lymph nodes, effusion, or mediastinal masses. Again, much less common, but abdominal ultrasound is critical. And it's not enough just to do an ultrasound. We need to look at the spleen and liver and aspirate them both. We'll get to that in a minute. The third test that we want to do in cases with poor prognostic indicators for staging may be a bone marrow aspirate. The pro is that it's supported of systemic mastocytosis if there are clinical signs. And obviously the problem with bone marrow aspirates is they're expensive, invasive, and may be low yield. So it's certainly not something I do on a regular basis. So ultrasound is something obviously that many have in their general practice and that we use all the time. And so a couple different studies have looked to see, is it enough to do an abdominal ultrasound in cases with mast cell tumor, or do we actually need to aspirate this liver and the spleen? And this is one of those studies that was done, and it tried to determine the correlation between the ultrasound and what they saw and the fine needle aspirate findings. And so they looked at 82 dogs, 18% had early visceral metastasis, 7% had overt metastasis on cytology. And what they found was that ultrasound in imaging was a poor prognostic predictor of metastasis. So 17 dogs have hepatic metastasis, but when they looked just at how the ultrasound appeared, only 12 of them out of 17 had a normal appearing liver. So just looking at the liver is not enough. You need to aspirate it. Same with the spleen. 3 dogs had normal spleen and 9 had splenic metastasis. So the take-home message here is that ultrasound is good, but it's certainly not enough without a fine needle aspirate. So which prognostic indicators are those that are going to make us decide whether we want to just do minimal staging or complete staging? 1 second, sorry. So the prognostic indicators that we're going to discuss today are grade, stage, breed, location. Okay, obviously growth rate and duration are pretty obvious. If you have a tumor that's grown to the size of an orange within a week or two, that is bad. If you have a tumor that the owner has been there for a year or two and it's the size, 1 centimeter, then obviously that's better. Look, recurrence of a tumor is obviously not good. And then we have all sorts of different things that you can send for cytology, for biopsy, like PCNA and Ki-67. So obviously grading is something that we all learned about in vet school. So mast cell tumor was the first tumor that it was shown that grading was a prognostic indicator, and that was very, very important in veterinary medicine. And that article was done, the first article was done by Patnick in 1984, which was quite a while ago. And so what he showed, again, first time in veterinary medicine, was that the higher the grade, the worse the prognosis. So pretty much you can grade any tumor in veterinary medicine, but the only reason to grade a tumor and to make your pathologist spend that time on grading is if there's prognostic significance. So if you can grade it, but it has no correlation with survival, then there's no point. But what he showed is, again, higher the grade, the less they lived. And here you can see here that he looked at the percent of dogs alive at 1,500 days and saw that in grade 1, almost all of them were alive, and grade 3, only 6%, which is a huge difference. And you can see here on the right, the Kaplan-Meier, that the lines are separated very beautifully. And obviously grade was at that time very, very significant. However, over time, Dr. Nicole Northrup said, wait, we're having some problems. So the problems that we were having with grading were, 1, almost all of the pathologists were grading everything as a 2, and we barely saw any grade 1 or grade 3 tumors. So people started looking at mitotic index within the grade 2s to see if it was more significant, because the grading wasn't helping because everything was a grade 2. And then so what Nicole did is she gave many biopsies of mast cell tumors to 10 different pathologists at her institution and asked them to grade 60 different tumors. And so what she found was that there was a huge variation among the pathologists when grading. So if as oncologists, we thought the grading was like the gold standard, all of a sudden she found out, no, if you give the same tumor to different people, they'll grade it differently. So there was agreement between all 10 pathologists on only 4 out of 60 tumors, 3 high grade and 1 low grade, which means that this grading system, even though it worked for Patnick, it clearly was not working for veterinary oncology. So based on different problems and this study, in 2011, Cupel actually came out with a 2-tier histological grading system, which is now used. So he split mast cell tumors into low and high grades, and his purpose was actually to get a grading system that anybody can use. So he tried to make it much more easy for the pathologist. So he had very clear criteria, and mast cell tumor high grade was based on the presence of any one of the following criteria. And he said, okay, pathologist, take this, look at this. This is easy. You can do it. So he split it into high and low, and then he found that the median survival for high grades was less than 4 months, and for low grades was more than 2 years. So obviously this has huge advantages. There was low and high grades. Prognosis was very different between low and high grades, and it was supposed to be very easy for the pathologist to use. However, One of the major problems is that all of the articles that we had until this grading system started to be used were on 1, 2, and 3, and not on low and high, which made it is still difficult for us to use that information and to switch it over. The other problem was that people started looking and seeing that many of the dogs with high-grade tumors were not dying within 4 months, which as oncologists probably problematic, because an owner comes in and we're like, okay, your dog has a high-grade tumor. The median survival is 4 months. And obviously, if the dog's going to die in 4 months of his cancer, we need to give it chemotherapy. And then, so this article was published in 2020 by Tony Moore that looked at 49 dogs with cupal high-grade clinical stage 1 cutaneous tumors. And he said, whoa, these dogs lived a median survival time of over 1,000 days, which is clearly very different than 4 months. And then he tried to understand what was special about this subgroup of dogs. And so in this group, he saw local recurrence in 9 dogs, lymph node metastasis in only 6 dogs, new mast cell tumor in 15 dogs. And what he found was the tumor location, histologic margin size, and chemo didn't affect median survival. And obviously, we were giving chemo to all of these dogs because they all had high-grade tumors. What he did find were negative prognostic indicators was the mitotic count and the size of the tumor. And the 6 dogs that developed lymph node metastasis obviously had a worse median survival of 450 days versus 1,645 days. Again, 451 days is certainly not 4 months. So he found a group of dogs that were diagnosed with high-grade tumors, but still lived much longer than the original cupal paper. So his study suggested that dogs with local surgical control of clinically stage 1 histologically high-grade cupal cutaneous mast cell tumors may have a long survival time, especially those with small tumors and with a low mitotic count. So the take-home message from this article for you is that even with the new grading system, please don't rely only on the histologic grade when predicting survival for dogs for mast cell tumors. So after grade, we have stage. So the staging is split into 4. Stage 0 is an incompletely excised tumor, obviously post-surgery. 1 is a tumor confined to the dermis. 2 is the dermis and 1 lymph node. 3 is the multiple or large infiltrating tumors with or without a node. And 4 is distant metastasis. And this staging system is kind of problematic because, let's say, Siggy is a multiple tumors, even though she doesn't have a lymph node. So let's keep that in mind because there may not be a correlation between the higher the stage, the worse the prognosis in every case. So based on this staging system, a very important article was published in 2015. So what they wanted to see is what happens to these grade 2 stage 2 canine mast cell tumors. So a dog that has had a mast cell tumor that was surgically removed and had metastasis to that regional lymph node and had local therapy with adjuvant systemic chemotherapy and removal of that lymph node. So up until 2015, a lot of people said, okay, if I have a mast cell tumor, which is locally excised but has metastatic lymph node, it's metastatic. So, okay, let's just either give the dog chemotherapy or tell the owners it has a really bad prognosis. So what this paper has come to tell us that even dogs that have stage 2 mast cell tumor, again, grade 2, not grade 3, which now is really problematic because we don't have grade 2, but let's say low grade metastatic mast cell tumor to the local lymph node still had a really unbelievable prognosis. So even with lymph node metastasis in grade 2 mast cell tumors, with a combination of chemotherapy, surgery, with or without radiation, they had a median survival in the excess of 40 months. Again, metastatic disease still living a very, very long time, which is very important to understand in this disease. On the other hand, we looked at staging, so we had stage 2, and now we're talking about stage 4. And stage 4 is distant metastatic disease. So in 2018, this article looked at dogs with stage 4 cutaneous mast cell tumors. So again, metastatic disease in 45 dogs, and they found a median survival of 110 days. So very, very different, much, much worse. The negative prognostic indicators in this study were tumor diameter over 3 centimeters, more than 2 metastatic sites. So the previous article was talking about 1 metastatic lymph node, and here we're talking about more than 2 metastatic sites, bone marrow infiltration, and lack of tumor control at the primary site. So the take-home message from this article is that stage 4 mast cell tumors have a poor prognosis, and therefore staging and diagnosis is critical. Because if you have a dog with 1 metastatic lymph node and you don't stage it, and you don't know if the dog is a stage 2 or stage 4, then the chance in prognosis is over 1,000 days to 100 days, and it's probably going to change the owner's decision on what to do, and it's definitely going to change your decision on what to recommend. So staging is critical. So breeds, the critical things to understand are that Shar-Pays, no matter what happens with a mast cell tumor, it's bad, bad, bad. They have a higher occurrence of grade 3 in inguinal tumors versus other breeds. So pretty much every time the Shar-Pei comes into me with a mast cell tumor, I'm going to treat it as a high grade, and even if it's diagnosed with a low grade, because they just respond really poorly. Boxers actually have more well-differentiated tumors, and pugs have a tendency to have multiple cutaneous tumors. Locations with worse prognostic indicators. So locations with increased risk of local lymph node metastasis are the muzzle, the oral mucosa, oral mucocutaneous junction, perineal area, inguinal area, vulvar area, scrotal area, and the subungual area. So after we diagnose the mast cell tumor, we staged it, we know if the dog has any specific poor prognostic indicators, then the next thing, obviously, we want to do is understand the treatment and prognosis. So what treatment options do we have in veterinary oncology? We always have the option of doing nothing, which I always offer my owners. But if they want to treat, we either have surgery, radiation, or chemotherapy. And we have to understand what the best combination is for the dog in front of us. So if we can do surgery, surgery is always the best treatment we can do. And if we do surgery and we get dirty margins, then we can either consider a second surgery, or if not, if it is impossible, we could either do radiation or electrochemotherapy to try to clean out those margins. In some cases where we're worried about metastasis, or we have a metastatic lymph node that we've removed, or we can't remove, then we may recommend chemotherapy. Again, low grade 2 with poor prognostic indicators, or an all high grade. And in some cases, when we have gross disease in these cases, we want to use supportive care with H1, H2 antagonists, and possibly proton pump inhibitors. So one very important article that discussed margins was published in 2004. So until that time, it was basically written in every surgery textbook and in every oncology textbook that mast cell tumors require very, very large margins. So what it was written is that you need 3 centimeters in every direction, and everybody pretty much couldn't get 3 centimeters in 80% of the tumors, because some of them are on the legs, and you just can't get those kind of margins. And everyone was like, oh, we're getting dirty margins and we need to do radiation, we need to do chemo. And clearly many of these tumors were being overtreated. So that's why Sue Murphy did this article in 2004, which was excellent on a huge amount of dogs compared to most of the veterinary oncology literature. She was 280 dogs and 340 mast cell tumors. And so what she showed, and you can see in this table, is in the grade 1, she had 87 grade 1 tumors. None of the dogs died of disease, and they were all alive at 1 and 2 years. The grade 2s, she had almost 200 tumors, which is a huge amount. The median survival wasn't reached, and 92% lived 1 year and 89 2 years. And then the grade 3s, again, this was all pre-cupal, 54 tumors, and their median survival was 278 days. Again, a very high median survival. So regarding regrowth, because what she really wanted to look at was what happens in these tumors if we don't get good margins. So only out of 340 mast cell tumors, only 23 had tumor regrowth. Of those, 3 had complete margins, 2 had narrow margins, and 14 had incomplete margins. When she looked at the grade regarding regrowth, 1 grade 1 recurred, 12 grade 2, and 10 grade 3s. So the very important conclusion from this article was that wide surgical margins are not a prerequisite for a successful long-term outcome. So this really changed the way that everybody was looking at these mast cell tumors. And we could change the way, and we could tell the owners, okay, even if we do a small surgery and we don't get great margins, still these dogs may be okay. And not every mast cell tumor is going to recur locally. So a couple of years later, quite a few years later, a review was done looking at surgical margins for mast cell tumors. So they looked at all the different papers that had done on mast cell tumors because quite a few have been done. And so they said, again, traditionally, we had requested huge margins, and clearly that is way too much. And their conclusions were that resection of grade 1 and grade 2 mast cell tumors, if the tumor is under 4 centimeters with 2 centimeter lateral margins and 1 facial deep plane, results in low rates of incomplete excision and local tumor recurrence. So again, even if you get dirty margins, the chances of recurrence are about 30%, which is not the end of the world. Another important thing is that if you see that there's no way you're going to get 2 centimeter lateral margins, so you're not going to get clean margins, or you see that there's no way you can go deep enough, there's no point in going 2 centimeters wide if you're not going to get clean margins laterally. So then it's probably better to do a marginal excision, wait for it to come back, or send these dogs off for radiation or electrochemotherapy to clean the margins. So the next treatment option is chemotherapy. So the general consensus, as I said before, is it's given in low-grade tumors with poor prognostic indicators or high-grade tumors. And the drugs that we use are prednisone, vinblastine, CCNU, and then the tyrosine kinase inhibitors, either Masivit or Palladia. There are many different articles about a lot of different drugs, and you can look into them if needed. So back to Siggy. She had 3 masses, all under 1 centimeter, cutaneous and easily movable. All of these masses were diagnosed as mast cell tumors, and we removed them surgically. So are we going to recommend additional treatment now? Are we going to tell the owners, oh my God, she had 3 mast cell tumors, you might as well, say goodbye? So again, we're going to look at the literature, and what you can find is that there were 2 different articles written on this subject. I'm just going to share one of them with you from 2006. So this looked at prognostic factors associated with the outcome with multiple cutaneous mast cell tumors treated with surgery, with or without adjuvant treatment. So just like her case. So there were 54 dogs with a minimum of 2 simultaneous histologically confirmed mast cell tumors that had been excised. So the median disease-free and survival times weren't reached. The 1, 2, and 5-year survival rates were 87 and 85% respectively, and the metastatic rate was 15%. The only negative prognostic factor was clinical signs at the time of diagnosis. So the take-home message here is that multiple mast cell tumor does not mean the dog has a poor prognosis. So again, thinking back to the staging, so stage 2 was a metastatic lymph node, and then stage 3 was multiple tumors with or without nodes. So if we have multiple tumors without a node, actually stage 3 has an excellent prognosis if there's no lymph node. So are we going to recommend additional treatment? No. She has an excellent prognosis, even though in the future, if she has already had 3 mast cell tumors by now, she may have additional mast cell tumors. Obviously, that's something that drives the owners crazy because they keep seeing these pop up in the dogs and they want some amazing solution, and we have absolutely no solutions for them except removing them surgically. Because these dogs have a tendency for mast cell tumors, we're probably going to remove them surgically. Each time we want just a marginal excision and not, cutting up the whole dog because of these mast cell tumors that are going to keep coming. But surgery is the only treatment we can recommend. Obviously, in cases where you have access to Stelfonta, you could considering that too, depending on the location of the tumor. So the next case that I wanted to share with you is Gemma. So Gemma presented in December, 10-year-old female spayed German Shepherd dog. In August, 4 months beforehand, she had had a mass removed between the digits of the right hind leg and was diagnosed as a low-grade mast cell tumor. A few days ago, she woke up and the right hind leg was swollen, and on physical exam, she had pitting edema of the right hind leg distal to the popliteal lymph node. The lymph node was enlarged about 4 centimeters. So obviously our problem list is an enlarged lymph node, and the plan would be to try to understand what's going on there. Differentials could either be metastatic or infection, and in order to understand what there is, obviously we want to aspirate that node. And unfortunately, this is what we saw on JEMMA. So again, we're seeing multiple mast cell tumor, mast cells, which would indicate probably a metastatic lymph node. When we have metastatic lymph nodes from mast cells tumors, sometimes we can have effacement of the entire node, and then it's really easy to diagnose because you can just see that the lymph node looks like a mast cell tumor. And then in other cases, we may have clusters, or we may have several mast cells, and then we have to send it for clinical pathology review to try to understand what's going on. But when the entire node is effaced, there's no question, which was what happened in her case. So what is our plan? What can we do here? So in this case, we need to stage. We need to understand, is this stopped? Is this a stage 2 tumor that only metastasized to that lymph node, but hasn't continued to additional abdominal organs like the spleen and the liver? Or are the spleen and liver positive? So we did an abdominal ultrasound, and we found that the liver was heterogenic, yet normal in size and shape. The differentials obviously are petopathy, hyperplasia, hepatitis, cholangiohepatitis, or neoplasia. And again, we saw that right lymph node was, popliteal lymph node was enlarged, round, hypoechoic, surrounded with edematous tissue. We have had cases, not like it didn't happen in Emma's case, where the whole area is so edematous that you don't even know where the lymph node is. And in those cases, sometimes it really helps to use the abdominal ultrasound in order to know where to aspirate in order to get your diagnosis. So if it's all edematous and you have no idea where to poke, then you can put the ultrasound on. You can see, like you can see here, exactly where the lymph node is, and then aspirate based on the ultrasound instead of just going into edema and getting a false negative response, right? False negative answer. So what now? Obviously, the liver doesn't look normal. And even if it did look normal, in order to understand whether JEMMA has metastasized or mast cell has metastasized to the liver and spleen, we need to aspirate both of those organs. Fortunately, in her case, we aspirated both the liver and spleen, and they showed no evidence of mast cells. So therefore, this tumor has metastasized to her local lymph node, regional lymph node, but it hasn't gone beyond that. So what are our options? Again, based on that article that I shared with you before, even with lymph node metastasis in grade 2 low-grade mast cells, the combination of chemo, surgery with or without radiation can give us a median survival in excess of 40 months, which obviously is pretty good. So the options, and I always give the owners options for her, are either conservative treatment, chemotherapy with prednisone, diphenhydramine, and omeprazole, and then chemotherapy. So whenever I have a dog with a lot of disease and mast cells, I will not give chemotherapy right away. First of all, I start with prednisone, diphenhydramine, and omeprazole. I wait 5 to 7 days. This reduces the tumor burden a little bit, and then I will start giving chemotherapy. And then the most aggressive option for her is to decrease the edema with prednisone, diphenhydramine, and omeprazole. If possible, remove that popliteal lymph node and then follow up with chemotherapy. So that's what the owners decided to do. We gave it, she had surgical removal of a popliteal lymph node, and then 2 weeks later, she started chemotherapy with vinblastine. So today she presented for our CBC and chemotherapy. However, on physical exam, we noticed that the distal part of the suture line, there was a little bit of mass-like lesions. The differentials obviously are inflammation or local recurrence. So I scanned the mass with the HT Vista. And unfortunately, as you can see here, she got a 3, which means that further investigation is recommended. So what are we going to do? Obviously, aspirate. So we aspirated that, and we got local recurrence of her mast cell tumor, which obviously was very unfortunate. So the significance of that is that there's local recurrence and tumor growth in face of treatment with chemotherapy with vinblastine, which means that there's no point in continuing with vinblastine. So then the options are either to stop treatment or to switch to another chemotherapy drug. So the next case that I wanted to share with you is Joy. She's an 11-year-old female spayed Labrador Retriever. A year ago, they went to a referring vet because she had a mass on her right hind leg. It was 2 by 3 centimeters. It was aspirated and diagnosed as a mast cell tumor. The popliteal lymph node at that point wasn't palpable, so they couldn't aspirate it, and the referring vet removed the mass surgically. And the biopsy results were a low-grade mast cell tumor with dirty margins. So what should they have done? So at that point, even if Joy had come to me for a second opinion or for an oncologist opinion, my feeling is that if a dog has a low-grade mast cell tumor with no indication of an enlarged lymph node with dirty margins on the leg, I probably wouldn't have recommended anything except for watching for local recurrence with a chance of about 30%. However, 2 months later, she presented with an enlarged popliteal lymph node, which was 4 centimeters. The referring vet aspirated it and diagnosed metastatic lymph node that was effaced by mast cells. So what now? So obviously in her case too, we're going to do an abdominal ultrasound and see what we find. In her case, unfortunately, she was much worse off than Gemma. So she had a few prominent lymph nodes, no evidence of free fluid in the sublumbar region with evidence of enlarged medial iliac lymph nodes. So here you can see in the pictures, the right sublumbar, the mesenteric lymph nodes. So she has very large lymph nodes. We're talking about around 4 centimeters. The one on the right is already 7 centimeters. She has huge lymph nodes in her abdominal cavity. So what are we going to do? Obviously, we want to aspirate those lymph nodes, which resulted in metastatic mast cell tumor. So as we discussed before, she has a stage 4 mast cell tumor. And based on this article, unfortunately, we had said that one of the poor prognostic indicators was more than 2 metastatic lymph nodes. And in her case, she already had more than 2. We could aspirate the liver and spleen, but my kind of belief is that if something is not going to change anything, then there's no point in doing the test. In her case, because she already had such huge nodes, the liver and the spleen weren't going to really help us at all, so we did not aspirate those. Unfortunately, there's no good treatment for stage 4 mast cell tumors, and she was obviously had huge lymph nodes, and the median survival was 110 days. So the options for her were either conservative treatment with prednisone, diphenhydramine, and omeprazole. Again, anytime you give prednisone for a dog with mast cell tumor and gross disease, you have to give diphenhydramine and omeprazole, because the prednisone, even though it's not chemotherapy, is going to kill some of those cells, causing degranulation. And then if you don't give the diphenhydramine and omeprazole, they may get sick just because of that prednisone that's killing those cells off. The other option is to start with the prednisone, diphenhydramine, and omeprazole, and then in 5 to 7 days add chemotherapy, again, with a very poor median survival. And the last case that I wanted to share with you today is Sherlock, a 7-year-old male castrated Doberman who's vaccinated, castrated, and lives indoors. He presented with a history of a mass that was removed from one of the hind legs a year ago and not sent for a biopsy. 2 months ago, they noticed there was a mass in the inguinal area about 20 centimeters. It was biopsied and diagnosed as a round cell tumor, possibly a mast cell tumor. And then a month ago, they did an additional surgery and sent it for biopsy, and it was diagnosed as a mast cell tumor. So when he came to me, he had a 15-centimeter mass in his inguinal area. So what now? What can we recommend and why? So usually these masses that we see that are kind of pretty much all of the inguinal area, clearly there's no surgical option for this dog. And no matter what we can do, we're not going to be able to get there. So in these cases, all we want to do is give palliative treatment to make his life as good quality of life for as long as he has left. So the options for him, again, conservative treatment, and then chemotherapy with a poor prognosis. But sometimes in these cases, we can really help a lot. So in his case, we gave chemotherapy with vinblastine. It lasted a couple months, really shrunk the tumor. Started growing again, we switched to CCNU. Lasted a couple months. The minute the tumor started to grow, we switched to Palladia. So we got him, quite a few months with a great quality of life. Every time the tumor started growing, the owners noticed it, and we switched treatment. So obviously, this is not right for every owner, but in some cases, even with really big mast cell tumors, which we know aren't going to live a lot, we can still improve their quality of life with chemotherapy. So I think that the most important take-home points is that mast cell tumors are complex tumors, and a great deal of research is required to understand more about their biologic behavior and treatment options. If we diagnose correctly and stage as required, we can offer the correct treatment options and give our patients the best quality of life possible. The treatment options are surgery when possible, with good margins if possible, radiation and electrochemotherapy if we can't good margins, chemotherapy in cases of high-grade tumors or low-grade tumors with poor prognostic indicators. And when we have no other options, we can give palliative treatment with prednisone, diphenhydramine, and omeprazole and help them really well. More important take-home points are that you should incorporate HT Vista into your hospital. You can know if a lump is benign without doing aspirates and biopsies. And with this new cutting-edge technology and a non-invasive approach, you can either know the mass is benign and safely send the dogs home, or recommend and rationalize the need to work up these cases with either aspirates or biopsies. This is the end of the wait-and-see era in veterinary medicine. So I would be happy to entertain any questions.
Thank you, Gillian, for a very good overview of clinical and science combined to go and give us an insight in things. So we've got some people in the audience there. Does anyone want to kick off with any questions? You just need to go and ask Gillian via the Q&A box, and that will start the whole process. Gillian, I have one question in regards of breed predilections. You know, we all know about boxers, but are there other ones that you're beginning to see more frequently with a potential? And also, does it, when you see a breed based on the grading, does any of the results show that certain breeds at a certain grade have a lesser chance?
So boxers have lower grade tumors. I think that we see a lot of pit bulls that also have, as in Siggy's case, multiple mast cell tumors, lower grade tumors. We also see Vizslas and Weimaranders sometimes with very small, low grade tumors. Those are the ones that we see a lot.
And is it also complicated? I mean, I saw a lot of your research came from the USA. I presume that's quite useful because it's a numbers game as well. And sometimes if you look at an individual country, which is small, you might skew the results just because the population of that breed is quite limited.
Most definitely. Anytime I'm talking to the owners, and referring veterinarians, I always say, your one case that you remember, you know, that either did really well or really poorly, means nothing. What you need to do is quote the results of the articles with their median survivals, because you always remember the best or the worst.
Yeah, understood. And it sounds like, I mean, things are, you know, from when I graduated are a lot better in regards to some of the chemotherapeutic options that are available. And you just don't just automatically just go and remove the lesion. You know, you look at other options as well.
Definitely. I think that the option of, in many cases, if a mass is too large, with decreasing the size of the mass with prednisone, vinblastine, and prednisone, diphenhydramine, and omeprazole, and then sending it for surgery, or even giving one dose or two doses of chemotherapy so that surgery can be much easier, is much more important. And also that we no longer believe that you need those 3 centimeter margins, which were very problematic.
Yeah, no, especially on the lower limbs.
Yeah.
Yeah.
No question.
That's quite a big quantum leap compared to where we were.
Right. I think that everybody understands that, you know, until the article by Sue Murphy in 2004, that there's no question that the years before that these tumors were being way overtreated, and pretty much every dog that had dirty margins was being sent for, you know, 15 to 18 treatments of radiation, which wasn't needed. But I mean, we learn over time and we change what we recommend.
Okay. All right. And in regards of your use of HT Vista in the clinic that you're working at, so proactively, I mean, I appreciate that it's often your clinical nurses or your vet techs who are doing the scanning for you. Is that correct? And then once you've got those results, you're then obviously analyzing the results and making a decision process based on all the factors in front of you. But are you scanning almost every case that comes in with anything looking slightly suspect to a mast cell tumor?
So everything I get as a veterinary oncologist, almost all the tumors that I get are already diagnosed. That's
Okay,
that's the way they can only come to me after they've been diagnosed. It's very
right, understood.
it's their dog with tumors that haven't been diagnosed, and I don't encourage it. But what we believe is that any dog that comes into a general practitioner with lumps and bumps should come in through the nurses, should be scanned, and then come to the veterinarian with those results for the veterinarian to interpret them and decide whether to send them home or to do a fine needle aspirate and save that time. We
Yeah.
believe that's much better veterinary medicine. Yes.
And initially, I mean, obviously there are a lot of mast cell tumors that are found on the lower limbs. And initially it was quite challenging to use HT Vista on the lower limbs because of the amount of skin surface. But I believe that there's been a development of certain ways that we can then improve our ability even on lower legs to be able to scan them. Do you want
Yes.
to
So
elaborate a
now,
bit on that?
well, I'm at home and I have nothing here. But basically, if this is the leg, and it was difficult to put the HT Vista here because there was air on both sides. So now there's something that you can actually put here, which will catch everything and just makes it much, much easier. But I mean, Liron, do you have that with you? I'm just like, I don't have anything.
I can see if I can get Lyron onto this. 1 second.
Sorry. I was
Mm,
not, I have nothing here.
That's
So
all right.
there was one, when you were asking maybe if anyone can help, one question on the chat, is there a correlation to other types of tumors developing alongside mast cell tumors or increasing their chances of other tumors, types of tumor metastasis with the same patient? So I don't think that the fact that a dog has mast cell tumors will cause them to get other tumor types. I think that we pretty much know that, any dog over the age of 10 is going to get tumors, and any female dog or even males are going to get lipomas. So that's obviously something that we see. I don't think there's a connection between a dog that's going to get a mast cell tumor and that might get a sarcoma or might get other tumor types. I think that a dog has a mast cell tumor it has more of a chance, especially if they're a younger dog, of having additional mast cell tumor in their lifetime because maybe something is wrong with them a little off genetically. So I think any dog that has a tumor has to be monitored more carefully over time.
Okay. Lyron, do you have any comments in regards of scanning lower limbs?
Hi, sorry, I don't have my camera kind of on at the moment. But yes, I mean, like Gillian mentioned, we have a special glove that we provide together with the HT Vista, which allows the kind of to seal all the air gaps. So we are now able to scan lower limbs, if it's small limbs or bigger limbs. But regardless to the size of the limbs, we have a special equipment that can help with the situations to make sure that the heat is distributed evenly along the tissue that is being scanned, and that's how we get very accurate results for those lump masses as well.
Yeah. And Gillian, one of those dogs that you were talking about, the German Shepherd, actually, it was within its interdigital area. Is that possible to scan that, or is that the one area which is still quite challenging?
Actually, with her, we scanned the recurrence of the tumor in the lymph node area. Because the referring vet actually had removed the primary tumor before she even came to me. Liron, what do you think about that?
Sorry, can you repeat the question, Stephen? So one of Gillian's cases was talking about a lymph node, or not lymph node, sorry, a mast cell tumor that was present in its interdigital area.
Oh, I see, yes.
Is it possible to scan something on a foot, or is that still a bit of a challenge?
No, absolutely not. I mean, it's absolutely fine. The only area that might be a little bit challenging is the foot pads. But anything around the digital area or kind of dorsally, should be okay. As long, in terms of the device, what it does, it uses healthy tissue, healthy skin as a reference to analyze how the suspicious area is behaving from a kind of thermodynamically point of view. So as long as you scan a piece of healthy skin alongside the suspicious area, that's absolutely fine. So the area will be used as a reference to do all the mathematical calculations and tell us what the device thinks or what the algorithm thinks about the suspicious area.
Okay, sounds good. And is there any other things that you specifically would like to mention at the moment, Lyron, whilst you're on?
Yes, I mean, I guess we will probably have very good very exciting announcements very soon. So stay tuned. We have managed to develop quite a few new algorithms that allow the HT Vista to transform from a screening tool to a diagnostic tool as well in some cases. So, and the performance of the algorithms that we are currently working with is quite amazing. We are talking about, I think Jidan mentioned the sensitivity and of 90% and the negative predicted value of 98%. And the diagnostic algorithms that we are now kind of creating and working with show very kind of amazing performance of specificity of 90% and over. So stay tuned. Within a couple of weeks, we are launching a new software that incorporates some more kind of diagnostic capabilities of the HT Vista. So it's transforming from screening only to screening and also have some diagnostic capabilities. So that's quite exciting, and we're looking forward to sharing it with everyone.
Yeah, that sounds amazing. I mean, you know, the great thing about your technology is the fact that sort of learning ability to improve that algorithm. So it's constantly going and getting better through, you know, your collaboration with certain clinics so that you're able to follow the case the whole way through. So I think that's really great.
Yes, absolutely. I mean, all the development that we are showing is actually due to or thanks to collaboration with GPs and oncology clinics that contribute to the database basically that we have. So all the validated scans that they contribute go into the algorithm and improve the performance of the algorithm, the current algorithm, and also allow us to produce and create and train new algorithms. So this is very, very exciting.
Yeah, no, that sounds brilliant. And the cost of the product itself is very reasonable, isn't it? I mean, I think we've gone through a number of different ways to help people make it a profitable center for a clinic. But you know, you're talking literally maybe scanning a dog a week and charging for it, and you've more than paid for the machine. So I think that people, when they think that you know, they sort of feel a lump and they sort of have a little conversation with the client, and the client maybe is a bit, you know, maybe apprehensive about doing a needle biopsy. I think the facilitation and, as you said, the improvements in specificity and sensitivity of it mean that it's a very quick process. It's only a 40-second process, isn't it, within the clinic?
Yeah, absolutely. And I think the most important message is that, you know, the technology and everything we do, the most kind of the one thing that we are trying to avoid is to send patients home without doing anything. And unfortunately, we have about more than 50% of the masses, as far as we are aware, go home undiagnosed. And this is where the HT Vista kind of bridges between this gap, because we don't want to send patients home with cancer. We want to make sure that all the masses that we see in clinic are being scanned, screened, and then those that require further investigation are highlighted to us, so we don't send them home. And then we pursue with kind of further investigation if it's cytology or histopathology. But we really kind of want to avoid wait and see approach. And we are kind of really hoping we are offering a tool for both vet professionals, but to pet owners as well, to make the best decisions for the pets.
Yeah. And I was looking at so in regards to the payment structure, you know, a lot of vets and the audience and nurses will appreciate that a lot of capital equipment's bought through finance to sort of spread the cost. And you know, we have an agreement with Braemar Finance, which is a good relationship to be able to go and offer the machine. But also, some of the costs are very, very reasonable in regards of it. If a practice wants to purchase, and obviously there are certain tax benefits as well, isn't there? So I think you're offering a sort of an outright purchase, a 2-year or a 1-year, and even a monthly plan. But I think you know, most people have opted for maybe a 1-year plan, and then they've upgraded to purchase outright after that period of time, haven't they?
Yes, I mean, to be honest, I mean, the purchase option has become the most popular. I guess because people prefer to own equipment rather than just list it.
Yep.
So yeah, in the last kind of year or so, the purchase option has become more popular, and as you've mentioned, because we see so many lumps and bumps in clinic weekly, clinics pay back for the device within about 3-4 months, and within the purchase option, you also get a 3-year of unlimited usage and warranty with the device. So if within kind of 3-4, even 5 months, you pay back for the device, you have more than 2.5 years to benefit from a device that kind of generate a good income from you. So you can obviously save lives, but at the same time grow your clinic. So this is another kind of benefit from kind of having the device in your clinic.
I was just going to show this. So this was a 2024 figures. But I think this is what you're talking about, isn't it? And some of it's been upgraded since then. Is that right, Byron?
It's slightly different, but quite close. But
Getting clear, yeah. Okay.
Yes.
That's what I had available at this point in time. But
yeah, no, absolutely.
there are
But
lots
again, you know,
of
the
options
best
available,
the best thing to do is, the best thing to do is just to book some time to talk with us, and we can go through everything on all the options. And as you've mentioned, we also have an option to support clinics with financing, so they can spread the cost. Yeah.
Any other comments? I can't see any more Q&As. No, I can't see. I think you've answered all the questions so far. Any other comments at all from the audience? I know we haven't lost anyone, so they're still listening, so it's good.
Brilliant. I guess I want to take this opportunity to thank you, Stephen, and VBS for allowing us to obviously talk about this topic and also share our technology with everyone. So thank you very much.
I appreciate very much, because I know from Gillian's point of view, obviously, it's pretty late at night over in Israel now. So I really thank you for joining us at this time.
You're welcome. I didn't fall asleep on you.
You're looking bright and shiny eyes. Yeah, and thank you, Lyron. So we know HT Vista give us a lot of good support in the UK. And our team are available to go and help you and give advice out. And we can, we've got some nice little short presentations if you have other members of staff who'd like to go and learn a bit more, and increasingly across both the corporate and the independent sectors, this has become a really useful tool, which definitely wasn't available when I was doing general practice, to allow us just that peace of mind and a better conversation with the client, and just do more within the confines of what we're able to do without having to maybe straight away refer, or the first we see a lump, or maybe not do so, be so proactive. So this is a great tool, and a great step forward. And as Lyron said, because of the feedback system, the technology is improving all of the time. So the ability of the sensitivity, the ability of the prognostic capabilities of this is from the moment you buy it, will only get better, which is a great thing. Most things devalue the moment you buy them. Okay. I thank you, everyone. I thank you, Gillian. I thank you, Lyron, for coming in and adding your piece of wisdom. I wish you well, everyone. I don't think there is anything else. We have other webinars coming up, so please go to our VBS Direct website. I know my team is available to help you along with the support from Gillian and Lyron and the rest of the HT Vista group. So thank you very much for tonight. I hope that was useful.
Thank you very much.
Take care.